it gets a little bit daunting. Preceptors are impossible to find. Yeah, do you guys agree with Alexis? What do you guys think? Starting second rotation in February, graduated in August. Interesting. So you graduate, but you're now doing your rotations. Am I understanding that correctly, Alexis? Is that right? Or am I totally off? Let's see how we can get. Okay, so I think we are streaming on YouTube. Yay, that's working. Let's see if we can get Instagram up and running. Let's see, let's see. I think we have a good shot. Let's see if I can get this to go. Finished my last rotation in August. Okay. Oh, and you're graduating in February. Okay, so you're done with your clinical rotations. I see. So you're getting ready to test for your boards. Is that right? Did I understand that right? What's today? Let's see if we can try this one. All right. Who else? Great. Who else is in the audience today? I know for those of you just joining us on Restream, the chat should be up and running now and it's working. So those of you joining on YouTube, go ahead and introduce yourselves to me. Where are you joining from? Where are you in your nurse practitioner journey? I just want to know where you guys are at. Um, while I try to figure out the tech end of today. Here we go. All right, looking promising, guys. Kept that music on. Oh, okay. So you're going into your rotation. I see what you're saying. Okay. Thank you for the clarity, Alexis. Let's see if this is gonna work. Can't hear you anymore. That's because I wasn't talking, Tiffany. That's fair. I'm trying to get the tech working. Can you hear me now? Should be able to hear me now. Yes, no, barely. Okay. Let's see. I've got some good stuff for us today, so I want to make sure you guys can hear me. How about now? Is that better? Is that better? No? No, the same. Okay, let's see what we can do about that. All right, see what we can do with that. Let's fix this. Fix it here. Go here. Now, is that better? DNP studying for boards. Hi, Ufa. Am I saying that right? Afua? Alexa, is that better for audio? Yay! I think that's better for audio. And I'm pretty sure our streaming is working now too. Let's double check. Let's see, let's see. Maybe not on the other channels. Maybe? Maybe. I think I got it to work, you guys. Okay, super excited. Apologies for the delay, but we got it all to work, I think. I think we're ready to rock and roll. So again, backing up, looking for an online RN program. Eunice, registered nurse from Kenya. I love it. Okay, Lakeisha, Hunter, Alexis, Tiffany. See, now I'm not distracted. I can engage with you guys. All right. Well, welcome, welcome. Happy Wednesday. For those of you, again, who don't know me, my name is Hiva Kolodrubetz. I'm a family nurse practitioner. I've been with Archer for a few years as an educator. Prior to that, well, I'm still practicing, but prior to that, a decade of experience in internal medicine and also specialty. So cardiology and pediatric endocrinology are my two loves. This webinar is going to be really engaging. So I know it was slow to start, but we're going to rev it up. I really like to get into practice questions and help you guys break down practice questions. I do a lot of tutoring one-on-one with my students. Yes, Fab says, do you have a one-to-one? That's exactly what I love to do. So get on our website. At the end, I'll also show you guys where you can find that schedule. But if you can't find it, you can scan this QR code, brings you to all our family nurse practitioner products, including our tutoring one-on-one with myself and Dr. Morgan Boosie. And that's what you're going to get a little taste of today, what we talk about in those tutoring sessions. So rapid 30, let's get started. And here's my name. Thank you for all those who joined on Zoom, who were really patient with my tech issues. All right, you guys, like I said, this is going to be interactive. So I want you to open those chats. Whatever platform you're on, I want you to engage with how we're going to answer these questions. This is a method that I use with my students when I'm working with students one-on-one. I find that students have a really tough time really slowing it down and breaking down those test questions. So this is a method that we've discussed, we come up with, and we practice. And this is what we're going to put into practice today. How are we going to break down those test questions? So can we start FNP after BSN? Yes, to Nisha, there are a lot of programs out there that help you get an MSN. You can exit at the MSN level or continue on to the DNP. So in those test questions, you're going to get really meaty test questions. Why? The board's exam is really focused on critical thinking. They want to make sure that you're not just memorizing and regurgitating. They want to know you are going to be a safe clinician when you enter clinical practice. So entry-level knowledge, you don't need to know everything because it continues to be a learning curve, especially for those first 2 to 5 years. It's really going to be a steep learning curve. So I always tell my students, find a supportive environment. You want to make sure that people are coaching you and understand the investment that it takes to hire a new grad. But these clinical questions are really going to be checking that critical thinking. What do you do? Are you going to be safe out there? So let's talk about what that means when we're breaking down those test questions. So read the question, ask yourself, what is it asking? So pause, what is it asking? Go back through, read line by line, pull out those keywords that really help you answer the question, right? You can get really caught up and confused in how thick these questions are, but know what it's asking, go back, break it down, pull out those keywords to help you answer the question. And then before even looking at the answer choices, answer it in your own words. The reason why I say that is because a lot of students start to really talk themselves out of the right answer when they really might do something differently when they have that patient in front of them. They'll try to mimic that clinical scenario, right? So answer it in your own words and then go through the answer choices and pick out the ones that best align with your answer. If we get down to a couple that we don't know, don't overthink it. Choose the best one and move on. If you're studying, that's exactly where we want to dive deeper and focus our study plan. A lot of students get really confused. There's a lot of noise out there right now, and their study plans are not focused. By the time they get to me, they're so confused. Come to me earlier. First of all, we'll keep you focused. And secondly, just really focus on the areas that you don't know. Don't shy away from that. That's exactly what studying is supposed to be, right? All right, you guys, so let's break down these practice questions. So I see Tiffany, Afua, Alexis, all engaging with me, Lakeisha, and you're so welcome, Aunt. Okay, and I see our friends on Instagram too. Welcome, welcome. Can you zoom into the presentation? The letters are small. Okay, so let's see. This should be a little bit better because I put a bigger font in there. All right, so let's practice this first one. Again, remember, it's really thick, right? Students get really confused. I've broken it down just to help guide your eyes in this presentation, but let's break down using that method that I just showed you guys. 24-year-old patient presents to an outpatient clinic With a 2-day history of acute sore throat and fever, patient reports painful swallowing and fatigue. Denies cough, rhinorrhea. On exam, they're giving you the temp, 101.3. That's Fahrenheit for those of you joining us internationally. We also have Celsius on there for you. Tonsillar erythema with exudate, tender anterior cervical lymphadenopathy, lungs are clear, point of care testing, that's what POC is. Point of care testing, and on exam, they'll write these out. I'm just using shorthand just to save some space on this slide. Point of care testing, rapid strep is positive. Patient reports a penicillin allergy stating, I was told I was allergic as a child, but is unable to recall the specific reaction. Which of the following is the most appropriate next step in management? All right, what's our first step? What is this question asking, right? Throw it in the chat for me. What is this question asking? Which of the following is the most appropriate next step in management? Is this an assessment question, diagnosis, plan, evaluate? What is this question asking, you guys? Put it in the chat. Come on, come on. You know you want to. All right, Alexis is saying plan. Do you guys agree with Alexis? Is this a plan question? Yes, no? For the most part, maybe. We're super confused because there was so much information. All right, they're asking us which of the following is the most appropriate next step, right? So we want to know, what do we need to do with this patient? They're giving us a lot of information. Let's go back and see what information. 24-year-old. Whenever they're giving you that demographic, pay attention. 24-year-old, outpatient clinic, 2-day history, acute sore throat and fever. Those are all key words, right? This should help you really figure out the stability of this patient. I have a spectrum of stability that I go over with my students, really thinking about, is this someone who's stable? We're going to be managing them in that outpatient world. Or is this someone who's not stable and they need higher level of care, right? So they're setting the scene for you. 24-year-old comes in, outpatient clinic, 2-day history, acute sore throat, fever. So stable, not stable, throw it in the chat for me. Patient reports painful swallowing and fatigue, right? So going back to that sore throat, painful swallowing, fatigue, right? These are review of systems that they're telling you. Denies cough or rhinorrhea. So in reality, you're going to be an astute clinician, ask these questions, but they're giving it to you, right? So do they have a cough? Do they have rhinorrhea? No, right? No other signs or symptoms other than really focal pain in that throat and some generalized fatigue and fever, probably some body aches. Temperature showing you 101.3 Fahrenheit. Tonsillar erythema with exudate, right? That should be a red flag with exudate, right? Those tonsils, erythema, red, swollen, exudate. What's exudate, you guys? All right, Ant is saying this patient is stable. What's exudate, you guys? It's pus. Yeah, exudate is pus, right? What causes pus? Let's think about that. Tender anterior cervical lymphadenopathy. So again, textbook, lungs are clear, nothing going on in the lower respiratory tract. Positive rapid strep test. So they're telling you that you should be leaning towards this as potentially strep. And all those things really do meet how strep presents, right? Really focal, painful swallowing, might be a little fatigued, no cough, nothing else going on, and that anterior cervical lymphadenopathy with that tonsillar erythema and exudate, right? Patient reports a penicillin allergy stating, I was told I was allergic as a child, but is unable to recall the specific reaction. What does this make you think? And then what's our next step? So we are suspecting strep. Patient thinks they might have a penicillin allergy, but they're not sure what that reaction was. So take a look at the options A, B, C, or D. What is our next step in this patient's management? All right, Kim says administer antibiotics. I am ADF says antibiotics and pain management. Okay, so a lot of you would jump to antibiotics, which is good. We want to treat this patient, so that rules out D, right? Withhold antibiotic therapy and provide supportive care. Why do we treat strep? Strep is self-resolving. Why do we treat strep, you guys? Yeah, ant pus. Very good. Yeah. What about you guys on Zoom? You're quiet. All right, Tiffany. PSGN. I don't know if I know what that acronym means. Spell it out for me. What do you guys think? Why do we treat strep throat? All right, a lot of you are saying C, 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 C. Is C the right answer? Let's see. All right, you guys. Okay, post-strep glomerulonephritis. Okay, risk for rheumatic fever is what I was looking for. Very good, you guys. So we treat strep because of the risk that it can develop into rheumatic fever and cause valvular issues. Bonus point, who knows which valve gets most impacted by rheumatic fever? Bonus, bonus. Who knows? Mitral. Tiffany, awesome job, you guys. That's right. And C is the correct answer. It leads to further complication. Very good, you guys. So strep is self-resolving, but it leads to further complication if we don't treat it. We see a lot. I ran the valvular clinic in my cardiology life, and we saw a lot of mitral valve issues that were really indicative of this patient had rheumatic fever. Now, this is an older patient population where they didn't treat strep throat as readily with antibiotics, but absolutely, we need to treat strep throat and not just withhold medication. Why are we not doing azithromycin or clindamycin? Why are we clarifying? Because we actually don't know, and we don't want to completely eliminate something great like cephalosporins because we don't know if this patient had a severe penicillin allergic reaction, and we don't want to escalate and cause resistance. Very good, you guys. All right, next one. 52-year-old adult. Are we getting it? How we want to break these down? And I have like 50 slides for us today, so let's see how many we can get through meaningfully. 52-year-old adult presents to primary care clinic for evaluation of a new rash. Patient was started on Bactrim, so it'll tell you Bactrim as well. I wrote these, so this is good feedback for me too as I'm trialing out these new test questions. So I'll put Bactrim in there so you guys have the brand name. On boards, they'll always give you generic and brand. 12 days ago for uncomplicated lower extremity cellulitis, which has been improving. Over the last 3 days, the patient reports fever, malaise, painful burning sensation of the skin, followed by a rapidly spreading rash on the trunk, upper extremities. Exam reveals dusky erythematous macules with purpuric centers, marked skin tenderness to palpation, crusted erosions on the lips, conjunctival injections. Rash is not confined to the original cellulitis site. There is no history of autoimmune blistering disease and no recent viral illness. Which assessment best explains this patient's current presentation? So what is this question asking? Assess, diagnose, plan. They tell you, but we're going to pause and think, okay, this is an assessment question, right? Very good. Okay. Lakeisha's thinking, okay, we need to figure out, hi, Robina, we need to figure out what's going on with this patient, right? Do we think it's cellulitis getting worse, or do we think it's something else happening? So we need to assess this patient's acuity, what's happening. 52-year-old patient, primary care, new rash, right? Patient was started on Bactrim, which we use a lot, especially for if we're suspecting MRSA 12 days ago, and it got better, improving. So they're telling you, pull out those keywords. They're telling you that cellulitis has gotten better. Over the past 3 days, patient reports this new finding, right? And on the exam, they're describing it to you. So derm, we really need to figure out how is it written out, right? We may be able to recognize it, but we have to picture it in our minds. How is it written out? So what do you guys think? A, B, C, or D? What's going on with this patient? Is this patient stable, not stable? Are we worried about this patient? What do we think, you guys? A, B, C, or D? Okay, Aunt says allergic reaction. Do you guys agree? Is this an allergic reaction? What do you guys think? Hi, Arisa. Hi, Shab. Hi, Jose, Herman. What do you guys think? A, B, C, or D, you guys? And I know we're kind of like, oh, that was a tough one. Did I throw a tough one at you? Okay. Shia is saying C. Anybody else want to give it a whirl? Yeah, this is pretty classic Steven Johnson syndrome. And the reason why I threw this in here is if you don't know how Steven Johnson syndrome presents, you need to know, because there are medications that we commonly prescribe, like Bactrim, where this is a potential adverse event or adverse reaction, right? Typically, the difference between just a simple drug eruption and Steven Johnson is the timing, right? If this patient really had a response to the drug, it's a simple drug eruption, it would be sooner, within 1 to 2 weeks. Stevens-Johnson's typically is more delayed, right? And we see a lot more of that painful burning sensation on the skin, and then it starts to spread. And then it's also telling us a little bit more about how that Stevens-Johnson syndrome, pretty classic textbook. So this patient suspected Stevens-Johnson syndrome, emergency, non-emergency. Is this patient stable? What are we going to do with this patient? What's that next step? Yeah, very good, Anu. Very good, Alma. ER. Yeah, we're going to send this patient to higher level of care. Very good, you guys. All right. Mrs. Dill comes to the primary care clinic complaining of urinary frequency, urgency, dysuria for 3 days. She's afebrile, denies flank pain, states she found out she is pregnant 2 weeks ago. She will see her OB next week. Urine dipstick was positive for nitrites, and the NP decides to treat her for the UTI while awaiting cultures. Pretty classic, right? You're going to see this a lot. You're going to get patients calling in UTIs a lot. So you're going to get really comfortable with how you're going to prescribe for UTIs and how you're going to rule in, rule out complicated versus uncomplicated, right? Nurse practitioner chooses which of the following to treat her suspected UTI. Remember, what is the question asking? This is a treatment question, a plan question. So you as the nurse practitioner, you're going to have to choose which of the following to treat her UTI. So they're already telling you what she has. Pull out those key words. What is it telling you here? A, B, C, or D? What do you guys think? A, B, C, or D? What are some of those key words? Throw it in the chat for me. Pregnant. Okay. Afua says D. Yeah, pregnancy is a big key word, right? So in pharmacology, we always want to look at age, pediatrics, geriatrics, pregnancy. We want to look at liver, renal issues, right? These are all things that are going to change the way we're going to prescribe to make sure we're prescribing safely. So Afua says D. Do you guys agree? We're going to give Rocephin to her. What do you guys think? A, B. Ooh, we're split. I love that. That means there's room to learn, right? We're split between A and B. So the answer is A, you guys. So in our pregnant moms, amoxicillin is going to be our first line. Very, very good. Excellent, excellent job. Okay, if that's a knowledge gap, write it down. Go read some more between, go learn about uncomplicated versus complicated, and then those outliers, right? With pregnancy, kids, geriatrics, and those side effects. 56-year-old male presents to the primary care clinic, urinary frequency, urgency, dysuria, suprapubic discomfort for 4 days. Patient reports chills, mild left flank pain, discomfort, but denies nausea or vomiting. Medical history is significant for type 2 diabetes, BPH. Current medications include metformin, tamsulosin. Vital signs are stable with a temp of 100.4 Fahrenheit. Blood pressure, they give that to you. Heart rate, they give that to you. Exam reveals mild CVA tenderness on the left side. Point of care testing, UA is positive for leukocytes and nitrites. Empirical antibiotic therapy is planned while awaiting urine culture results. So this, you are being an astute clinician. You are sending it out for culture because why? Is this patient complicated or uncomplicated cystitis? What is the most appropriate next step in management? Okay, so what is this question asking before going back through here? What is the most appropriate next step? So we're really looking at the plan, right? And we have to evaluate how stable is this patient. When they give you a demographic, pay attention, right? 56-year-old male. So is this patient complicated or uncomplicated? Throw it in the chat for me. Complicated. Alexa says complicated, send to the ER. What do you guys think? Are we sending this patient to the ER? Jasmine says maybe, yes, no. Lakeisha, Ant, what do you guys think? Adolf, Gloria, what do you guys think? Tiffany says complicated, but can manage an outpatient. Afua says complicated. Okay, I love it when you guys are split. This is fantastic. All right, so I think for the most part, we agree this patient is complicated. Let's look at those risk factors for complicated, for what is considered a complicated cystitis, right? So his gender, male, already puts him in that complicated category, right? We worry about that infection getting worse. Very good. Yeah. Other things that we're worried about. So Tiffany pointed this out. He's got type 2 diabetes, right? That also puts him in that complicated category. Very good. The point of care testing is telling us, okay, we definitely think something's going on. We see those nitrites. Leukocytes, nitrites tell us there's some sort of breakdown from our immune system and that bacteria. So we're going to start him on empirical therapy, but we really need to escalate this therapy, right? So we're worried that this is complicated. So A, B, C, or D, what do we think with this patient? Tell me what you think, A, B, C, or D. Yeah, Tiffany's worried about pyelo, the CVA tenderness. Yeah, they describe mild CVA tenderness on exam, and I think that's why some of you are split whether we're going to manage this patient outpatient or inpatient. So A, B, C, or D. So I see a lot of people locking in that answer. What do we think, A, B, C, or D? All right. You guys are kind of split, mildly complicated. Okay, I like that. I can't hear. I think we fixed the audio issue, but maybe not. Is that better? Did I have you guys muted? I don't know. All right, we'll fix that later. All right, so the answer is C. Absolutely, you guys. So this is a complicated scenario, so we need to elevate to Cipro. Both choices A and B are for uncomplicated cystitis, right? And then choice D is if we think we're going to send this patient on the inpatient side, they might do some IV ceftriaxone. So in this scenario, patient is stable. We're going to manage them in the outpatient side, right? All right, we're coming up to that half an hour mark, but we had some tech issues, so I'm going to go a little over. If you guys need to drop off, that's okay if you plan for 30 minutes. If not, I'm going to go through some more questions in the next 10 minutes and then we'll hop off. Okay, you guys? All right, so, and I see the screen went blank. Not sure what's happening with Instagram. Let's retry. Okay. All right, you guys. Mr. Lyle, 33-year-old male, comes into the urgent care claiming to have been bitten by a tick this past weekend while on a hike. Nurse practitioner notes that he has an erythematous migraines rash to the back of his legs where he claims the tick bit him. Nurse practitioner wants to begin treatment while he awaits testing results. Which antibiotic class is the first line treatment, A, B, C, or D? Again, what is this asking and what are we thinking we want to do as that first line treatment, right? Some of you are locking in the answer. So Tiffany says B, doxycycline. So know your class of medications, right? Doxycycline is a tetracycline. Very good. And then when are we going to be doing macrolides? When are we going to be using our fluoroquinolones, cephalosporins? What are those side effects that we're watching for? Very, very good. Do we agree with Tiffany, you guys? Yes, B is the right answer. What are we treating here? Lyme disease. Very good. Yep, we're treating Lyme disease, that classic erythematous migraines. First line is going to be doxycycline, which is a tetracycline. All right, what about if a 6-year-old child comes in to the clinic, 5-day history of expanding rash on that left thigh? Family reports recent hiking in a wooded area in the northeast United States. Physical exam reveals a 7-centimeter erythematous rash with central clearing consistent with erythema migrans. Patient reports mild fatigue, headache, but denies neck stiffness, facial weakness, palpitations, chest pain, joint pain. What are we ruling out there? What are they telling us? Is this patient stable or unstable? Vital signs are stable, growth and development appropriate for age. Patient has no known medication allergies, no chronic medical history. Which of the following is the most appropriate next step? So again, what is it asking? Absolutely, we're thinking Lyme again, but that demographic is 6-year-olds. This patient stable or unstable? Afua says stable. What do we think, you guys? A, B, C, or D? What's going to be our first line with this patient? Okay, Afua says B. Do you guys agree? That's right, Belle. Lyme disease is what we're treating. Yeah. But in our patients who are under 8 years old, can we do doxycycline? Can we do tetracyclines? Tiffany says B. Yeah, AAP guidelines say yes, especially if it's a short course, right? Tiffany says no, risk of teeth discoloration. So that is absolutely where I was trying to make sure we filled that knowledge gap, right? With Lyme disease, with Rocky Mountain spotted fever, we can do doxycycline as our first line therapy according to the AAP because the benefit outweighs the risk. So teeth discoloration is absolutely a side effect of doxycycline for under age 8. for those of you who will be seeing our pediatric patients. However, because it's a short course, that is still our first line. Very good, you guys. So again, filling in these knowledge gaps with these test questions is really important. That's my goal for writing these new test questions. So you guys are giving me some good insight on whether what you think and how you're interpreting these test questions, and if the wording's confusing or helpful. All right. 41-year-old adult presents to the primary care clinic with a 3-day history of a painful skin infection on that left thigh. Patient reports progressive erythema, warmth, swelling, and tenderness that began as a small spider bite-like lesion and rapidly enlarged. Exam reveals a 7-centimeter area of induration with central purulent drainage. Patient completed 48 hours of Keflex and prescribed, again, I think I have to put in those brand names, so cephalexin or Keflex, prescribed in an urgent care clinic with no improvement. Patient reports a history of a prior skin infection requiring incision and drainage while incarcerated 2 years ago. Vital signs are stable. Based on the likely diagnosis, what is the most appropriate next step? So what is this question asking, you guys? What is this question asking? Is this an assess, diagnose, plan, treatment, a plan evaluation? What do you guys think? Absolutely, Fua. This is the plan question, but it's not giving you the diagnosis. It's giving you clues. You have to list out your list of differentials based on those keywords, based on your diagnosis, what is going to be your next step. And I have some friends already putting it in there. They're worried about MRSA. All right, let's look at the test question, the answer choices, A, B, C, or D. What do you guys think? So my friend Vo says MRSA is what we're worried about. What clues us into MRSA, you guys? Why are we worried about MRSA in this scenario? Those risk factors. What are some of those risk factors? This person's incarcerated, has been incarcerated, right? History of incarceration. Let's go back. So a history of incarceration, right? They're describing that it's getting worse, tenderness, that induration is purulent, right? That purulent discharge is what we're worried about. And then no improvement with first line with Keflex, right? So we're definitely worried about MRSA. So based on that, what's going to be our next step? So I see Tiffany says B, we'd initiate oral antibiotics with activity against MRSA. Would we continue the Keflex therapy and reassess in 72 hours? Yes or no? Why is that not right? We should see some improvement within 48 to 72 hours. So it's telling us that the patient has not improved. So why would we continue that treatment, right? That is negligence. That's not something that's going to help this patient. We're not going to do that. What happens if we give this patient topical corticosteroids? Is that going to make the situation better or worse? Definitely, it's going to make it worse. Absolutely. So we do not want to do that, right? And then refer immediately for surgical evaluation. Are we worried about necrotic tissue or necrotizing fasciitis? No, right? They're not describing that. They're describing MRSA. Very good, you guys. All right, 1-month-old male arrives at the clinic with a fever. Mother states he will not take his bottle at all today. Upon further exam, he cries when the pen light shines in his eyes and his fontanelles are bulging, which is the most appropriate next step. So it's asking you, what are you going to do with this case? Again, not giving you the diagnosis, wants you to be thinking about your list of differentials and what do we need to do? Is this patient stable or not stable? Let's back it up. 1-month-old male arrives at the clinic. He's got a fever. Mom states he's not taking his bottle today. So feeding issues, right? That's a problem. On exam, he's crying, he's got sensitivity to light, and his fontanelles are bulging. What do bulging fontanelles tell us? Yeah, Tiffany says not stable. Fua says not stable. I agree. This patient is not stable. So what is this bulging fontanelle telling us? What's happening with this patient? Yeah, increased intracranial pressure, right? Something's going on. What can increase ICP, intracranial pressure, right? Maybe infection, inflammation from infection or inflammation from something else, trauma, brain tumor, but we are definitely worried. Why is this baby not feeding? Why is this baby not being comforted? fever under 2 months, that's a big problem, right? And then those bulging fontanelles. So what's our appropriate next step? A, B, C, or D? Tiffany says D. Afua, what do you think? Do you agree? D, we're sending him to the ER. Yeah, this patient's not stable. We are sending him to the ER. Very good. Nurse practitioner. And then those are the types of questions in our explanation, our Q bank. We're going to be talking about things that increase that intracranial pressure, like encephalitis, meningitis, hydrocephalus. So we really are going to break that down so that you can fill in those knowledge gaps. Nurse practitioner is counseling a 32-year-old female with a history of migraines with aura on hormonal birth control options. Which medication would be the best recommendation? A, B, C, or D? What do you guys think? Josephine says A. What do you guys think, Aunt? Belkesh? Go to the ED, said Aunt about the 1-month-old. I agree. Afua says A. Yeah, A is the right answer. And why? Hormonal birth control options. This is the only one that's progesterone only. That estrogen absolutely increases that patient's risk for what? Tiffany says no estrogen. Yeah, for clots. Very good, you guys. Awesome. That's right. So with this patient, she's 32, so that's good. She's not over the age of 35, so 32 years old, but she does have a history of migraines with aura. So know your red flags, know those contraindications. This is an absolute no-no. Will increase her risk for blood clots, heart attack. Absolutely, Afua. Yeah, am I? All right, I think we're gonna get through one more and then we'll wrap it for today. And I think we got through quite a few, so that was pretty good. 62-year-old male presents to the urgent care complaining of severe left-sided headaches with nasal congestion occurring every afternoon. Which headache type is the first in your list of differentials? A, B, C, or D? What do you guys think? Afua says C. What do you guys think? And just thinking about it. What do you guys think? What do you guys think? That's right. C is the right answer. And again, knowing the difference, how these different types of headaches typically present is really important. So secondary could be something like sinusitis, so you could get that frontal headache. However, in this, it's giving you demographics. So male patients are more inclined to be experiencing that cluster headache versus females experience more migraines. That doesn't mean that in real life you can't have a male patient who's experiencing migraines and vice versa. But when they're giving you that clinical vignette, they're giving you textbook. So male, we want to be thinking, okay, at more increased risk for that cluster headache, complaining of severe left side headaches. So cluster headaches come on hard and strong and fast, 10 out of 10, and then they go pretty quickly too. Whereas migraines is more slow and more of a prodrome with those auras or no auras. And then it's going to take a little while for it to go away. So this is a patient who just needs quiet, calm, dark room. And then that associated nasal congestion, right? That's going to be that watering of the eyes, the nose. That's pretty classic with the cluster headaches and occurring every afternoon. Pretty classic for cluster headaches. So again, when you're breaking down these test questions, you really want to be thinking about what is the question asking? Let's go back to that slide. So what is the question asking? Let's go back to my methods slide. What are those keywords? Pull them out line by line to help you answer that question. So don't get yourself confused. Answer it in your own words and then go through the answer choices and rule in or rule out the ones that make the most sense. All right, you guys, I want to hear your feedback. How did this go? Did we like the test questions? Did we not like the test questions? What do you think? I also want to highlight that we now have updated our live reviews. They are monthly. They're on the calendar between now and June. So definitely check out our live reviews. This is really, you're so welcome, Alexis. So anytime you guys need help, you can email me. This comes to me directly at advancedpractice@archerpulse.com. I highly, highly recommend, with all the noise out there, with all the different products out there. I have students who come in and they've purchased a lot of different products, and half the time they don't use any of them. And that's a lot of money, right? Those are like streaming subscriptions that you just never use and you don't even remember you had anymore. I want you to find a question bank that you're really confident about. And then also, so 3 things. So 1, find a good question bank to practice as you're studying. To have your study materials, your go-to of where you're going to read, that's credible, right? Where are you going to read more about this to learn more about those knowledge gaps that you have? Those questions are going to help you identify those knowledge gaps. Your textbooks I say textbooks because that's my generation and I really like textbooks, but making sure you're going to the right sources to fill in those knowledge gaps. And then you have support, right? Anytime you run into an issue where you're like, you know what, I just don't understand this, I need to talk this out, whether it's a small study group or one-on-one tutoring with myself or Dr. Boosie, you have the support, right? And for those of you who are in programs where you didn't have the support, you know exactly what I'm talking about. You guys are all really smart, you're hardworking, but you need that support system not only to get across that finish line, but be successful in clinical practice. So making sure you find your community is really, really important. I tell my students that all the time. So those are the things to really focus on when you're getting ready for your boards preparation, entering clinical practice, going into your clinical rotations, whatever you want that prep for. Our one-day live review is really neat because we really pack it with a lot of these test questions. We give you a lot of content. So it's over 400 slides that you get PDFs of, really nice content. We don't go deep into the content. We literally just say, this is your scope of practice as a family practice nurse practitioner in primary care. This is what you need to know. These are the main points. Don't get caught up in the weeds of like, oh, this medication has that potential side effect. Really want to be thinking about high points. Like when somebody comes in and you're treating them for suspected Lyme disease, are we going to be prescribing doxycycline to that patient who's under 8 years old? What are we worried about with doxycycline, that potential side effect? But AAP says short course is okay. That's the kind of stuff we're going to be talking through in our one-day live review, right? The big high impact, so that you can identify those knowledge gaps, go back, read about them, and really learn the material so you can critically use your judgment, not only on test day, but when a patient presents in front of you. It's really, really important. Afua, thank you so much for joining today. Everyone, thank you for joining today. Please don't hesitate to reach out. Check out those live reviews. I always plan for more in these 30-minute sessions than I have time for. I love teaching you guys, but I was going to walk you through where we can find that. But if you guys scan this live review QR code, you'll be able to see it. I was going to walk you guys through our dashboard so you can see exactly how that looks. So if you want to stay on, I'm going to walk you guys through that dashboard for a minute. I can't help myself. So that's neat to see what we're talking about. So when you're in that dashboard, this is the NCLEX stuff. So my student account obviously has everything in it just because I work here at Archer. But when you're in that dashboard, depending on what you've purchased, the SurePass gives you everything. You're going to get your question bank. You're also going to see when those live webinars are. So Morgan has an awesome geriatrics webinar next week that y'all should check out, and that's free. It'll tell you which ones are free and which ones are paid. This is our power prep for February. It's happening on February 18th and it's all day. You get the recording, you get the PDFs, you get a workbook. It's a nice deal in my opinion. And then you can also see those mentoring sessions and what's open and what's not, and book with myself or Dr. Boosie. So in our question bank, when you're in there, I always tell people start with that readiness assessment. You can create a test. You go in, you have all these options. Just click on that readiness assessment, click which boards exam you want. It'll give you 75 questions, and then it'll take you through that readiness assessment and give you a prediction of where you stand, and you can see your progress that way. So when you end the test, it'll give you that analysis so you can review the results, where you stand in terms of chances of passing, and then you can go through line by line and see which ones you got wrong, which ones you got right, and read the rationale. When you're going through these test questions, I always tell my students, pause. You shouldn't really be blowing through these test questions. I want you to read the rationale, right? Whether you got it right or wrong, you want to make sure you understand that content and before you move on to the next one. What was this test question trying to teach me? And do I need to go back and review that content? So that's really, really important. All right, you guys, I'm going to hang on for a few minutes if you have any questions. Otherwise, it's been a pleasure. Great seeing you guys today. And thank you for all your participation. I want to hear from you. So throw it in the chat. Helpful, not helpful. You're so welcome, Betty, Jamila. This is a huge benefit. Oh, I'm so glad, Aunt. Oh, I love supporting you guys transitioning into the profession. So definitely reach out to me. Let me know how things are going, whether we've passed, not passed. I want to hear all of that, you guys. So really, really appreciate your time. Have a wonderful rest of your Wednesday, and we'll see you soon. And I think if you purchase the Sure Pass, you'll get the recording of the live review that we just did last week in January, since your test date's on the 18th. You're so welcome, Princess. But if you, Teresa, you're so welcome. But if you purchase that Sure Pass, I believe you get the recording. We don't have a live review before the 18th, unfortunately. We just did one last week. All we really have is the webinar that you're seeing on our schedule, and tutoring before the 18th. Sorry about that. But I'm pretty sure you can always email our support team and see how you can purchase that on demand of our live review, because that'll be really helpful. But good luck. Let me know how things go and how I can help you. That's going to be exciting.
The good news here is that there is so much.
Awesome, Aunt. Definitely email me if you have any questions or support. Support is always really good about reaching out to me for the answer. So definitely let me know how it goes. All right, you guys. And